Hello, welcome. Today we start the webinar of brain tumors. Introduction. Primary brain tumors are diagnosed in approximately 52,000 people each year in United States. At least one half of these tumors are malignant and associated with high mortality rates. Out of these, the tumors are glial tumors accounts for 60% of all primary brain tumors. Meningiomas account for 25%. Vestibular schwannoma accounts for 10%, and central nervous system lymphomas about 2%. Now, what are the clinical features of brain tumors? Clinical features are divided into two categories. These are general and focal. Patients often have a combination of the two. General or non-specific symptoms include headache, cognitive difficulties, personality change, and gait disorder. Generalized symptoms arise when the enlarging tumor and its surrounding edema cause an increase in intracranial pressure or direct compression of cerebrospinal fluid circulation, leading to hydrocephalus. The classic headache associated with the brain tumor is most evident in the morning and improves during the day. But this particular pattern is actually seen in minority of patients. Headache may be accompanied by nausea or vomiting when intracranial pressure is elevated. Headaches are often holocephalic but can be ipsilateral to the side of the tumor. Occasionally, headaches have feature of typical migraine with unilateral throbbing pain associated with visual scotoma. Personality changes may include apathy and withdrawal from social circumstances, mimicking depression. Focal or lateralizing findings include hemiparesis, aphasia, or visual field defect. Lateralizing symptoms such as hemiparesis are typically subacute and progressive. A visual field defect is often not noticed by the patient. Its presence may only be revealed after it leads to an injury such as an automobile accident occurring in the blind visual field. Language difficulties may be mistaken for confusion. Seizures are a common presentation of brain tumors, occurring in about 25% of patients with brain metastasis or malignant gliomas, but can be presenting symptoms in up to 90% of patients with low-grade gliomas. Most seizures have focal signature that reflects their location in the brain and many proceed to secondary generalization. All generalized seizures that arise from brain tumor will have a focal onset whether or not it is apparently clinical. Now, neuroimaging. In neuroimaging, MRI is the preferred diagnostic test. CT scan should be reserved for those patients unable to undergo MRI, example, patients with pacemakers. Low-grade gliomas typically do not enhance with gadolinium and are best appreciated on fluid attenuated inversion recovery MR images, aka FLAIR images. Now, functional MRI is useful in pre-surgical planning and defining eloquent sensory motor and language cortex. Positron emission tomography (PET scan) is useful in determining the metabolic activity of the lesion seen on the MRI. MR perfusion and spectroscopy can provide information on blood flow or tissue composition. These techniques may help distinguish tumor progression from necrotic tissue as a consequence of treatment with radiation and chemotherapy, or identify foci of high-grade tumor in an otherwise low-grade appearing glioma. Okay, now the treatment of brain tumors. In the therapy of any intracranial malignancy requires both symptomatic and a definitive treatment. Definitive treatment is based upon specific tumor type and includes surgery, radiotherapy and chemotherapy, while the symptomatic treatment includes the treatment of cerebral edema, seizures and venous thromboembolic diseases. Okay. Now moving on to primary brain tumors. Primary brain tumors. Etiology. The only clear risk factor for primary brain tumor is ionizing radiation. The latency between exposure and presentation can be 10 to 20 years. Radiation of the cranium can increase the incidence of tumors by up to factor of 10 depending on the tumor type. There is no clear evidence that power lines, cell phones and head trauma increase the risk of brain tumors. In most cases, the cause of primary brain tumor is unknown. Now moving on towards the astrocytomas. What are astrocytomas? Astrocytomas, these are infiltrative tumors with a presumptive glial cell of origin. The World Health Organization classifies astrocytomas into 4 prognostic grades based on histologic features. Grade 1, pilocytic astrocytoma or subependymal giant cell astrocytoma. Grade 2, diffuse astrocytoma. Grade 3, anaplastic astrocytoma, and grade 4, glioblastoma. Okay. The grade 1 and grade 2 both combined are known as low grade astrocytomas, and grade 3 and 4 combined called high grade astrocytomas. Okay. Now low grade astrocytoma. Grade 1. Grade 1 astrocytoma, also known as pilocytic astrocytoma, are the most common tumor of childhood. They occur typically in the cerebellum but may also be found elsewhere in the neuraxis, including the optic nerves and brainstem. Grade 2 astrocytoma, these are infiltrative tumors that usually present with seizures in young adults. High grade astrocytoma. Grade 3, anaplastic astrocytoma. These account for approximately 15 to 20% of high grade astrocytomas. They generally present in the 4th and 5th decade of life as variably enhancing tumors. Grade 4 astrocytoma or glioblastoma. Glioblastoma accounts for majority of high grade astrocytomas. They are most common cause of malignant primary brain tumors. Patients usually present in the 6th and 7th decades of life with headache, seizures or focal neurologic defects. Treatment of a glioblastoma involves maximal surgical resection followed by partial field external beam radiotherapy with concomitant temozolomide chemotherapy. Okay. The image showing the fluid attenuated inversion recovery FLAIR MRI of a left frontal low grade astrocytoma. This lesion did not enhance. Second image is showing post gadolinium T1 MRI of large cystic left frontal glioblastoma. Moving forward, treatment options for recurrent disease may include reoperation. The images you are seeing is first is post gadolinium T1 MRI of a recurrent glioblastoma before. First is before and second one is after administration of bevacizumab. Note the decrease, enhancement and mass effect. Okay. Moving forward, primary central nervous system lymphoma. Primary central nervous system lymphoma is a rare non-Hodgkin lymphoma accounting for less than 3% of primary brain tumors. For unclear reasons, its incidence is increasing, particularly in immunocompetent individuals. PCNSL is in immunocompetent patients usually consist of diffuse large B-cell lymphomas. PCNSL may also occur in immunocompromised patients, usually those infected with human immunodeficiency virus or organ transplant recipients on immunosuppressive therapy. PCNSL in immunocompromised patients is typically a large cell with immunoblastic and more aggressive features. Moving forward, the image you are seeing is a post-gadolinium T1 MRI demonstrating a large bifrontal primary central nervous system lymphoma. The periventricular location and diffuse enhancement pattern is characteristic of lymphoma. What is the treatment of primary central nervous system lymphoma? Unlike other primary brain tumors, PCNSL is relatively sensitive to glucocorticoids, chemotherapy and radiotherapy. Durable complete response and long-term survival are possible with these treatments. High-dose methotrexate, a folate antagonist that interrupts DNA synthesis, produces response rates ranging from 35 to 80% and median survival up to 50 months. Moving forward, what is medulloblastoma? Medulloblastoma are most common malignant brain tumors of childhood, accounting for approximately 20% of all primary CNS tumors among children. They arise from granule cell progenitors or from multipotent progenitors from the ventricular zone. Histologically, medulloblastoma appear as highly cellular tumors with abundant dark staining, round nuclei and rosette formation. Homer-Wright rosettes. They present with headache, ataxia and sign of brainstem involvement. On MRI, they appear as densely enhancing tumors in the posterior fossa, sometimes associated with hydrocephalus. Seeding of the CSF is common. Treatment involves maximal surgical resection, craniospinal irradiation and chemotherapy with agents such as cisplatin, lomustine, cyclophosphamide and vincristine. Approximately 70% of patients have long-term survival, but usually at the cost of significant neurocognitive impairment. A major goal of current research is to improve survival while minimizing long-term complications. Now, pineal region tumors. A large number of tumors can arise in the region of the pineal gland. These typically present with headache, visual symptoms and hydrocephalus. Patient may have Perinaud syndrome characterized by impaired upgaze and accommodation. Some pineal tumors such as pineocytoma and benign teratomas can be treated simply by surgical resection. Germinomas respond to irradiation, while pineoblastomas and malignant germ cell tumors require craniospinal radiation and chemotherapy. Moving forward with meningiomas. Meningiomas are diagnosed with increasing frequency as more people undergo neuroimaging studies for various indications. They are now the most common primary brain tumor, accounting for approximately 32% of the total. Their incidence increase with age. They tend to be more common in women and in patients with neurofibromatosis type 2. They also occur more commonly in patients with past history of cranial irradiation. Meningiomas arise from the dura mater and are composed of neoplastic meningothelial arachnoidal cap cells. They are most commonly located over the cerebral convexities, especially adjacent to the sagittal sinus, but can also occur in the skull base and along with the dorsum of the spinal cord. The images you are seeing is of post-gadolinium T1 MRI demonstrating multiple meningiomas along with the falx and left parietal cortex. Moving forward with schwannomas. These are generally benign tumors arising from the Schwann cells of cranial or spinal nerve roots. The most common schwannomas, termed vestibular schwannoma or acoustic schwannoma or acoustic neuromas, arise from the vestibular portion of the 8th cranial nerve and accounts for approximately 9% of primary brain tumors. Patients with neurofibromatosis type 2 have a high incidence of vestibular schwannoma that are frequently bilateral. Schwannomas arising from other cranial nerves such as the trigeminal nerve fifth, occur with much lower frequency. Neurofibromatosis type 1 is associated with increased incidence of schwannomas of spinal nerve roots. The image you are seeing is of post-gadolinium MRI of a right vestibular schwannoma. The tumor can be seen to involve the internal auditory canal. Moving forward with tumor metastasis. As you can see, most common source of brain metastasis are lung and breast carcinomas. Melanoma has greatest propensity to metastasize to the brain, being found in 80% of patients at autopsy. Most metastases develop at gray matter white matter junction in the watershed distribution of the brain when intravascular tumor cells lodge in the terminal arterioles. The distribution of metastasis in the brain approximates the proportion of blood flow such that about 85% of all metastases are supratentorial and 15% occur in the posterior fossa. The images you are seeing first is post-gadolinium T1 MRI of multiple brain metastasis from non-small cell lung cancer involving the right frontal, and second one is right cerebellar hemisphere. Note the diffuse enhancement pattern and absence of central necrosis. Leptomeningeal metastasis. You can see in the images post-gadolinium MRI image of extensive leptomeningeal metastasis from breast cancer nodule along the dorsal surface of the spinal cord, first one, and the second along quadra equina. The treatment of leptomeningeal metastasis is palliative as there is no curative therapy. Now epidural metastasis. The image you are seeing showing post-gadolinium T1 MRI showing circumferential epidural tumor around the thoracic spinal cord from esophageal cancer. Epidural metastasis requires immediate treatment. A randomized control trial demonstrates the superiority of surgical section followed by radiotherapy compared to radiotherapy alone. Thank you for listening of webinar on brain tumors. Hope to see you soon. Thank you. For any questions, feel free to contact us at support@scholarx.org.